Welcome to Interdisciplinary Case Miles, a podcast where real runner stories meet clinical expertise. We discuss real cases that are anything from weekend warriors all the way to elite athletes, while using our evidence-informed approach.
I'm Dr. Sara Raiser, a running medicine physician focusing on helping runners prevent and recover from running-related injuries while optimizing health and performance.
I'm Kelsey Pontius, a sports dietitian helping runners to fuel smarter, recover better, and help avoid the risk of injury so that they can meet their goals.
And I'm Dr. Mihevc Edwards. I'm a physical therapist and orthopedic specialist, and I've been treating for runners for over 15 years. And what I do is help them get back stronger and better. Hi, everybody. Welcome to Interdisciplinary Case Miles. And we are going to jump right in today with another case. We're so excited you guys are here with us. This case is a really interesting one, actually, and Sarah's going to lead most of it. But it is a 19-year-old male collegiate athlete that's coming in with exertional leg pain. So take it away, Sarah.
Sure. So I get these cases a fair amount, and I always have patients ask me, do you see this a lot? And I'm like, well, I see it a lot because we're a runner center here at University of Virginia, but these are actually relatively rare cases. So exertional leg pain means that folks are having pain between the knee and the ankle that happens when they are active. And in our scenarios, generally exertional leg pain means they have no pain at rest, and then they work out, pain comes on, stops them from working out potentially, and then it takes a few minutes to an hour or so for pain to go away. At some point, sometimes people can have pain at rest if they're really pushing it, but that's essentially the definition of exertional leg pain. So this can be pain in the calf muscles, this can be pain in the muscles across the front of the shin, the outside of the leg, the peroneals. We've got 4 compartments in the leg, and so all these different muscles potentially may be involved, and sometimes the nerves and the blood vessels can also be involved as well and contribute to pain. Sometimes pain will go into the foot as well. So in this particular case, this athlete basically just described having tightness in his calves. He's a high-level collegiate distance runner, and so he feels like this is really limiting his ability to perform at his best, despite the fact that he was able to manage to get through his seasons by modifying and kind of capping his volume and managing his intensity. So when I see these athletes, oftentimes they are higher level athletes. If I just told him that one of the treatments he could do is just stop running, he's going to look at me like I'm crazy. But it is an option, and I always make sure I tell people this. If you stop doing the inciting event, oftentimes they do just fine. But in this case, he wants to be a professional runner and wants to perform at his absolute best. So the things that we think about with this, so the compartments can be affected. So when we do exercise, our muscles expand, and that connective tissue or more rigid tissue around that compartment of muscles has to be able to comply and allow the muscles to expand. And if for some reason the muscles expand too much, or the compartment for some reason is tight, then you start getting compression when you exercise. So that can look like pain. It can look like numbness, tingling. You can have temperature, color changes down into the foot. And so everyone shows up with a little bit different symptoms, but generally there's some degree of tightness. You might touch the leg and it feels muscles feel hard. They may feel more engorged in dark red or purple. And then you may get numbness, tingling symptoms down into the foot when they're really getting at their worst. And usually symptoms will stop folks. So this is chronic exertional compartment syndrome that I'm referring to. And this is very different than acute compartment syndrome that is an emergent issue and requires immediate surgery. So this is more of a chronic condition. The other syndrome that I oftentimes will see in this exertional leg pain scenario is something called Popliteal artery entrapment syndrome. So it's a mouthful. PAES is what we usually refer to it as. And essentially this means that the blood vessel that goes back behind the knee potentially gets the supply gets cut off, or a component of it gets narrowed with one position of the leg. And oftentimes it's because it passes, under the calf, or it splits and goes through the calf muscles, what have you, a bunch of different scenarios that this can happen in. But because your blood supply is compromised, it can also give you this leg pain and numbness, tingling. Usually popliteal artery entrapment syndrome looks like symptoms just on the back of the calf and into the bottom of the foot. But these can all show up in kind of different ways, and everyone perceives pain a little bit differently. So oftentimes we end up working them up for both if symptoms overlap a little bit. So the most common one we see is where they have more symptoms across the front and the side of the leg. Those are our anterior and lateral compartments, and that's kind of our classic chronic exertional compartment syndrome that we work folks up for. Other things that we want to think about, I always rule out, does someone have a stress fracture? Because they can have symptoms show up in similar ways. And I also want to make sure they don't have a lumbar radiculopathy. So that's a nerve that gets pinched in the back that can also send pain down into legs. And sometimes they only experience pain from the knee to the foot without having any back symptoms or symptoms above the knee. So we want to rule all those things out. And then the compartment testing is the super fun part. So this is where we use a needle, and we actually put a needle that measures pressure into each of the 4 compartments. There's argument that you don't need to do one of them. But we do it on both sides before someone exercises, and then we have them exercise, get their symptoms ramped up as much as possible, making sure they're safe to do so before we do this. So rule out that stress fracture part. And then we get them back on the table while they're symptomatic and immediately try to recheck all these pressures again. If they are positive, fasciotomies is the gold standard to treat this. However, part of our scenario today is we want to talk about what it looks like to potentially try to treat this without going through the surgery piece, or what do we do after they've had their surgery and we're trying to optimize to get them back to a sport such as distance running. So that's a lot of information, but certainly this is a very kind of rare diagnosis, but I end up seeing quite a lot of it because it more often will show up in runners, or exertional leg pain itself will show up in runners in this scenario. Generally, when I see them, I end up diagnosing them with a stress fracture. They just, whoever they saw initially didn't think that was it. They just saw exertional leg pain and kind of honed in on that. But oftentimes I start with an MRI and just confirm that there's nothing going on the bone, and then we go from there. So usually we end up stopping at that point and not having to continue on. So when I got this particular runner on the treadmill, there were quite a few gait things that we saw. And if this was someone who had all the time in the world, not a finite number of collegiate years to train, and felt pressure to potentially do surgery, I would really consider doing some gait retraining. So this was a 4-foot runner. His heels never touched the ground. He had some heavy landings, and there were quite a few asymmetries and kind of inefficiencies in his gait. And so I would love for Kate to discuss some of the things that she sees with gait and how we might potentially address this. And again, this might be someone who tries to do all these things before ever considering a surgery versus someone who might also be going on, because we actually did a gait evaluation for this gentleman with the plan for him to go back and do some gait retraining as he's coming back from his surgery as well. So Kate.
Yeah, thanks. So I do see this actually quite often as well, because we are a clinic that mostly sees runners. So I think that that's what ends up happening, is they just end up coming through. And I've had both spectrums. I've had athletes that are elite athletes that end up getting the fasciotomy and go to surgery, and then, we treat after and they're completely fine. I have people who do not want surgery and they want to do everything that they possibly can, and we do that from a PT standpoint. I will say that can take a really, really long time. Much more time than most people want it to take.
Or never be effective, right?
Or never even be effective. So I do say that in the beginning, like the caveat is, I don't know if this is going to help or not. It very well could, because I have seen it help, and I have plenty of cases that it shows that. And there are plenty of other cases that we do everything, quote, right, and they end up having to have surgery anyway. So I would like to put that out there, that it's not a guarantee that the PT will help based on the pressures that are happening, based on everything else, but it can. And so from a gait perspective, it does depend on what compartment is impacted and what we'll kind of see in the gait area. So what you were talking about was some 4-foot striking, some really heavy landing. And you even said earlier, when we were talking earlier, that this athlete was overstriding. And we often also see people who have compartment syndrome do a lot of crossover gait. And that typically happens with that anterior lateral compartment, because what will happen is they will cross over and then their foot will land in that position where they're kind of in an everted position, and it'll overload that lateral compartment. So what do we do with an athlete like this? Gait retraining is different for everybody. And it can be, I will usually start with what's happening functionally. So what is happening in your squat, your single leg squat? What is happening with your heel raise? Can you do a heel raise and control it on the up and the down? So I'm looking at their functional strength. I'm looking at how they're moving from a manual therapy and their gait. And so I might be giving them a combination. I might be saying, hey, I really need you to work through this loading piece, being able to do these heel raises. I also will likely work on foot mechanics and stability, because a lot of times you have to work on that so that they can land better on their foot. I'm not necessarily going to say we're not landing on your forefoot. I might say, let's just try to get that foot closer to your center of mass and see where you end up landing. So that might be a cadence increase. So I might increase your cadence so that you can get that foot underneath you a little bit better. I may also put a piece of tape on the middle of the treadmill and try to make it so you're not crossing or having you look in the mirror. I might also have you work on your posture and your forward lean so you can get that foot underneath you. So those are all options that I would consider with somebody with exertional leg pain or some kind of compartment syndrome in terms of gait retraining. I will probably also look at the shoes that they're wearing. And one of the cues that, and I don't remember which research paper this was, but there was a research paper several years ago that came out about if you can get them to listen to themselves while they're running and cue them to land more softly, that'll change the way that they load that lower leg. So that's one of the cues that I often use in gait retraining is think about landing softly and listen to yourself as you land. And I find that athletes are really good at that cue because if they hear it loud, they know how within their body, whether they realize it or not, how to slow that down. Is that what you were looking for from a gait perspective?
That's excellent. And yeah, I always think about too with the heavy landings, is this just an overall general strength issue? Is there a core issue? So, I think that there's a tendency for sometimes folks to have a course of physical therapy before they see me, and the physical therapist may never have looked above their knee. And so really making sure that we've looked at their core, we've looked at the whole kinetic chain, are their glutes activating? Are there any major things that are going on that need to be addressed? And certainly I oftentimes see athletes when they are like at the end and they're like, I want surgery. And I'm like, oh, if I just have a few minutes to, potentially try some of this physical therapy that could actually address some of these frank things that we could see. And if I saw them and there was nothing for us to address, that makes sense. But oftentimes there's something that we can do. And I think it points out potentially some of the things that may have happened to cause the syndrome. One of the common ways this happens, or kind of a classic way that we think about this, is the athlete who goes to boot camp, joins military, and they have this really quick ramp up to heavy running loads, rucking, and strength training, and their calves get really big. And then we can have some problems from the exertional compartment standpoint, and we can't quite reverse that hypertrophy process that happened. So one of the things I was thinking about as Kate was talking is we didn't talk about why exactly this might suddenly occur. And oftentimes it's that calf development component of it, but it can definitely be mechanics too, which I think is worth looking into. I think to some extent, there's sometimes a point of no return when we develop this exertional leg pain. And by the time I end up seeing them, they've been dealing with it for quite some time.
Yes, that's definitely true. And like I said, I am thinking of a different case that we spent a year and a half working through it. And she does run now regularly, but she was the best patient in terms of following exactly what I asked. And we worked on everything from thoracic spine mobility and neural tension and pelvis all the way down to the lower leg. So we really had to address every single component, rotational stability, and making sure looking at how much pronation and how fast the pronation is, because that matters too. And looking at hip flexor strength, because if you have an anterior compartment issue and you're pulling up that foot every time you're trying to step, overusing your anterior tibialis, it might be because your hip flexor is really weak. So there are a lot of different things to look at and break down depending on the situation. Kelsey, I would love to hear now your perspective in terms of what you would do from a nutritional standpoint. And we had talked earlier about the blood flow idea before we started, but jump right in.
Yeah, totally. Unlike both of you, I don't know that I've personally worked on nutrition therapy for this specific thing, but sometimes it doesn't matter the exact diagnosis. It just matters what's happening in the body. So I think too, for me, it would matter like, when am I seeing this athlete? Is it when we're trying to do things preventing surgery or post-surgical? But I think if it was more on the side of, pre-surgery, trying to avoid surgery, I'd be focused on the blood flow element of it. So when we're trying to increase blood flow to the lower extremities, as both of you know, it's a really difficult place to get more blood flow. And so I think first of hydration. So I think Dr. Reiser said that this athlete was 19. And so I'd be curious about their basic hydration, what the quality of their nutrition is like, being in college, the access to food and everything, just making sure they're getting electrolytes, but not just eating a ton of salty food, because too much salt too can complicate, blood flow. And then really focusing too on anti-inflammatory compounds. And so I say compounds because this can fit into food or supplement routes. Being a collegiate athlete, sometimes we're more limited with supplement options because all supplements have to be third-party tested. And I like NSF for sport for collegiate athletes. So more limitations. And then it also depends too, like, what is the motivation of someone that's been dealing with the injury for that long in terms of remembering a supplement or going out and saying, hey, I'm going to go out and buy tart cherry juice, which is expensive. It's like $9 a thing. And so, just to name a few, tart cherry would be a big one. Sources of omega-3s, either supplement or food sources. And then nitrates too. Beets steal all the thunder for nitrates. They're vasodilators, but honestly, nitrates too are any kind of greens. I mean, even celery, carrots, that kind of thing too can help improve blood flow and are technically vasodilators, which are going to help that blood flow happen. Again, I think of this as like in combination. This is why we have a whole podcast of an interdisciplinary team. This is something that I think of like truly like managing symptoms. But I would be really curious of, what would it look like if an athlete was implementing all of these variables? And then Sara brought up a good point too before we hopped on here. Are they fueling correctly to adapt to the biomechanical work that you're doing? And so if we're trying to build strength and that requires new muscles, like, are we fueling enough to make the adaptations from all of that work too?
I forgot about that. That was a great, thank you for bringing that up because whenever you do gait retraining, it actually increases your oxygen uptake and it increases your metabolic needs because you're having to change the pattern in which you're running. And so it will be harder for you to do. And most people don't love the changes at first and they say, I'm slower, it doesn't feel as good. And that's because they're also metabolically changing. So thank you for bringing that up.
And whenever I feel like I'm getting stuck with athletes through physical therapy and I just don't feel like they're making gains, like I keep testing them every time they come back and they're not stronger. I'm like, are you doing your exercises? And like, show me how you do them. And those are times that I have conversations about, are we sure that the fueling is good? Mm-hmm. And they say, well, I eat healthy. And I said, well, healthy is not enough. Make sure we're eating sufficient amounts and getting the right nutrients because you still may be eating, quote unquote healthy. So kind of really digging into that more. And I've had a number of patients that are in that scenario where we have a lean runner and we're just not making any gains with physical therapy. And there's something going on there. And sometimes it's worth looking into hormones and, kind of diving deeper. But those are oftentimes things that I will look into as well. That's usually when I have someone for more longitudinal. The way things generally work is I'm getting someone when they're at their wits' end and they travel to come see me to get compartment testing. So I don't have the luxury quite as often for these scenarios. But I think it's really important to remember that just because you're not losing weight doesn't mean you're fueling sufficiently. So definitely kudos to Kelsey because I depend on her so many times in these scenarios of please just one visit at least, have a visit and see what they think and see what they have to say. And, let's go from there. But we are what we eat. So super important that we address that, right?
Yeah, I actually just sent someone to Kelsey last week that I was like, just one visit, just one visit and see what she has to say. After that, we'll figure it out. But please, if you've had injuries for this long and you don't have anyone in your corner for nutrition, you probably need her. So I agree. Kelsey is our secret ammunition in the background.
Sometimes we don't know why, but you just work on your nutrition and things get better.
That's right. But I also want to make this little comment. It could also be that they're not doing exercises that are functional for runners. This is a whole topic. And Kelsey made me think about it last week with the clamshell, which everyone who knows me knows that I do not like the clamshell exercise sideline.
I don't think anyone does.
It makes me crazy. I did make a video for you for Instagram, but I couldn't post it this week because of everything that was going on. But I made one of those videos. Kelsey was laughing the whole time. But no sideline clamshells, please. I'm sorry.
I've been doing them standing up since.
Thank you. I'm so happy. She said something at training camp about doing the clamshells.
No, one of the athletes was like, I know, Kate, I have to do them standing up because we always do them standing up. And I think I did a double take and I'm like, say that again.
So Kate, because the importance of what we're doing here on our podcast series, will you explain why we don't do clamshells?
Yeah, sorry. Sorry for this whole topic shift, everyone. Please stick with us for just another minute. So for runners, we need to do exercises that are functional, that'll actually help us with controlling our pelvis, controlling the loads that are coming up from the ground. Remember, every time you run, every time you step, you're putting loads that are at least 3 to 5.5 times your body weight through your body. If you're laying on your side doing a clamshell exercise, you might be changing that position of the muscle. The muscle might be contracting, but you're actually not challenging it in the same way that it needs to be challenged to help you during running. Because what that muscle does, or that clamshell, is working on gluteus medius. And gluteus medius, part of its job is to keep your pelvis level when you're in a single leg stance. And none of that is happening when you're on your side. So it literally makes me crazy whenever I see it. All right, so let's round this back up and bring it back on track. Why don't we each go through our top things, or Sarah, you'll start. Like, what are the 1 or 2 or 3 things that you want everyone to take from this podcast?
I think the biggest thing for exertional leg pain is making sure that you're ruling out all the other things that it could be and not just assuming it's chronic exertional compartment syndrome. So ruling out the stress fractures, addressing gait, doing the physical therapy, those types of things, because it's actually relatively rare. And ultimately, if we cannot do surgery, we would love to not do surgery. And I did want to put a quick plug in. We do have ultrasound guided fasciotomies now that we can do for anterior and lateral compartments that get people back to activity much quicker. You have to seek out the places that offer that because they are relatively rare right now, but we certainly do have things that are up and coming for treatments for this. But the biggest thing is making sure you're treating the right thing.
Yeah, as always, right? Kelsey, what about you? What are your takeaways from this episode?
I think the biggest thing when you've been an athlete that has been injured for a really long time and have been to multiple providers, it's very easy to feel overwhelmed and feel like you need the secret bullet that you just haven't found yet. But the first thing I talked about was hydration. And so just remembering before you get overwhelmed to really check off that you're doing the basic things correctly before, yes, there's time and place for like that tart cherry juice or whatever. But I think the basics just can help you manage so many issues.
I love that because I do think the basics get thrown out the window when we get frustrated and overwhelmed. And it's often the basics that you and Sarah and I end up talking to our clients about that really bring them back from the edge. Thank you for bringing that up.
I don't know from personal experience. I don't know that at all.
I know you don't. The last thing I want to say is one, that if you decide to come to PT for something like this exertional compartment syndrome or exertional leg pain, it's very possible it'll take a long time for you to get better from this. And it'll be a lot of work. It's worth it if you can do it, but it'll be a lot of boring exercises. I'm not really selling PT here right now. I'm sorry, but it can work, and I've seen it work. It's just you have to be prepared to really jump in for the long haul and understand that it may or may not work in the end. The other piece is make sure if you are going to a PT for this, that they're addressing all of the issues from foot all the way up through your spine. You want to make sure they're looking at neural tension. You want to make sure that they're looking at fascial mobility, how your foot is landing, how your foot is, how it's controlled in landing, all the way up through that rotational stability throughout your leg and your pelvis and your back. All right. Well, thank you very much for listening to us today. And as always, Kelsey and Sara, I'm happy to see you. If you guys like this podcast, please, please, please follow us. Give us some stars, send it along to your friends, share it away so that other people can hear this, and hopefully we can help somebody. I've been getting quite a few calls lately because of our podcast, and that's really been really rewarding to see that people are listening and that we're actually helping. So please spread the word. The other thing is, if you have a case you want us to go through, go ahead and email us. We have an email. It's runcasemiles@gmail.com. So we will see you guys soon, and have a great day.